This is a presentation about managing GP workload, including the interface between primary and secondary care, or when to say yes, when to say no, and why. I'm Paula Wright, I'm a GP, and you can contact me on my NHS Net address. The report Making Time in General Practice showed that 27% of GP appointments are avoidable, and you can see the breakdown here as to the reasons why. In the first video from my series of 3, I went through some of the reasons why it may be sometimes appropriate to say no to carrying out certain tasks, and I also referenced various national guidance documents which are illustrated here. The report Making Time in General Practice reveals that a proportion of avoidable GP consultations lie in control of the hospital. The first bar relates to 2.5% of GP consultations being connected either with DNAs leading to the need for a GP re-referral or failure to arrange follow-up by the hospital clinic. The second bar relates to 2% of GP consultations where the hospital staff will ask the patient to contact the GP for a prescription, for results, or for some other intervention, which was actually part of their hospital care. One of the difficulties that arises is when we get a request from a specialist in outpatients asking us to initiate a new drug. The letter often states, "Can you please start prescribing the following?" And on reading the letter, we're wondering, has the patient been counselled about risks, benefits, necessary monitoring? If this hasn't been documented, we don't know whether they've been counselled regarding these. Has the patient agreed to taking this medication? And because of all these uncertainties, inevitably, we think we have to invite the patient in to go through all these things and effectively complete the second half of the consultation, which should really have occurred in the specialist clinic. So let's look at these prescribing decisions in their component parts. The specialist makes a diagnosis, decides the treatment choice, and then informs the GP to prescribe. The problem is, it isn't quite so simple. The GMC guidance is quite clear that prescribing involves a number of tasks, and that therefore transferring this task to the general practitioner is not simply an administrative task, but infers a number of actions that have to be taken as part of a face-to-face consultation. So before you prescribe, you must obtain the patient's consent. Clinical records should include the information given to patients. You should reach agreement with the patient explaining the likely benefits, risks and burdens, including serious and common side effects, arrangements for monitoring, follow-up and review. It's essential for safe patient care that information about medicines accompanies patients or quickly follows them when they transfer between care settings. And when an episode of care is completed, you must tell the patient's general practitioner about changes to the patient's medicines, length of intended treatment, monitoring and requirements, and so on. The GMC guidance on prescribing is also very clear about delegating. If you prescribe at the recommendation of another doctor, you must satisfy yourself that the prescription is needed, appropriate for the patient, and within the limits of your competence. If you delegate assessment of a patient's suitability for a medicine, you must be satisfied that the person to whom you delegate has the qualifications, experience, knowledge and skills to make the assessment. You are responsible for the prescriptions you sign and for your decisions and actions. So the process is more complicated. Diagnosis must be followed by discussing treatment options, discussing risks, benefits, alternatives, titration, monitoring, and documenting this discussion in the notes, obtaining consent and agreement and documenting this, providing the prescription and outlining any monitoring requirements and interpretation of tests and acting on results. All of this forms part of the complete episode of patient care where a prescription is issued. So once all these have been covered, we're in a position to consider a safe transfer of prescribing from secondary care to primary care, and this will be determined by the local formulary and categorisation of the medications. So for medications in the amber category, they're governed by shared care guidelines. By Green Plus medications, this has to be initiated by the specialist and transferred to the GP with an information leaflet, and for the green category drugs, the handover is simpler. So let's look at the contract requirements for 16-17. Hospitals will not be able to adopt blanket policies under which all patients who do not attend clinic are automatically discharged back to their GP. This is particularly intended to address patients who DNA for the first time, rather than those who DNA repeatedly. Discharge summaries for inpatient, day case or A&E care should be provided within 24 hours by direct electronic transmission or email transmission. The discharge summaries must use the Academy of Medical College's endorsed clinical headings. Clinic letters following outpatient clinic attendance should be provided within 14 days, where there is information which the GP needs quickly in order to manage the patient's care. For a non-urgent condition directly related to the original referral, onward referral to another professional within the same provider is permitted without reference to the patient's GP. However, hospital clinicians are not permitted to refer onwards for non-urgent, unrelated conditions. Medication supplied following discharge from inpatient or day case care must now be supplied for the period established in local practice or protocols, but must be for a minimum of 7 days, unless a shorter period is clinically appropriate or where a repeat prescription is already in place. Providers are to communicate clearly with patients and GPs. This specifically includes notification to patients of the results of clinical investigations and treatments. So let's look at the contract requirements for 1718 and 1819. There is a new requirement on providers to issue fit notes to patients under their care where required under existing guidance from the Department of Work and Pensions. Outpatient clinic letters must be produced within 10 days from April 17 and within 7 days from April 18. From October 2018, they must be sent by electronic transmission as structured messages using standardized clinical headings. Providers are required to communicate properly with patients about their care by putting in place efficient arrangements for handling patient and GP queries. They need to publicize these arrangements on websites and appointment and admission letters. Providers need to ensure that they respond properly to patient queries themselves rather than passing them to practices to deal with. Electronic discharge summaries from accident and emergency must be sent as structured messages using standardized clinical headings from the 1st of October 18. Also from this date, transmission of both clinic letters and discharge summaries to general practice must be via direct electronic transmission, not via email. Outpatient medicines. Providers must supply medication following a patient's attendance at clinic where clinically indicated for the period required under local protocols, but at least sufficient to meet the patient's immediate needs up to the point at which the clinic letter reaches the GP. Hospitals must only initiate shared care arrangements where the patient's GP is content to accept the transfer of responsibility. Here's a summary of the hospital responsibilities in areas of interface with general practice regarding communications, prescribing and investigations. And this is in relation to outpatients and admissions and discharge. So let's look at the way the new contract impacts on surgical cases and the interface between primary and secondary care. The GP refers a patient in to clinic and a diagnosis is made and he's listed for surgery. However, inquiries during the period when the patient's waiting are often redirected to the community. There then follows the preoperative assessment, sometimes MRSA screening, and if needed, treatment for the results of the MRSA screening, then surgery, and then often attendance in the community again for a fit note and suture removal. Under the new contract, a number of these activities will be redirected into secondary care. There are a number of challenges to managing a situation where a breach has happened. First of all, you need to manage the patient safely and explain to them what's happening. Secondly, deflect the task back to the appropriate person. This will be appropriate in some situations and not in others. Educate and inform the person who committed the breach, manage your time so as not to exacerbate access problems, and log and notify these breaches to your CCG, LMC and Foundation Trust. The BMA has created a collection of templates that makes it easy to communicate these breaches back to the originating individual, and also to communicate them to local organisations. You're also encouraged to report them through your local significant event reporting systems. Part of making changes involves educating colleagues and patients. There are patient leaflets in existence that can be provided so that patients are clear of their expectations. It's important to educate our GP colleagues and also, whenever possible, to educate colleagues in hospital. One option for passing on feedback to local organisations is for GPs to use a monthly logging sheet such as the one illustrated here, where patient's NHS number is logged as well as the type of breach that has occurred. Obviously, for the purpose of sharing this feedback with the CCG and LMC, patient identifiable details must be removed. So educating patients is an important part of what will need to happen, and then there are a number of leaflets in circulation that do this, which cover these points. Thank you for watching this video. Do feel free to share and to send me your feedback to my NHSnet address or to follow me on Twitter. If you work in hospital, you may want to watch my other video on how to write fit notes, a brief guide for hospital doctors. Part 3 of this series covers dental problems, gender dysphoria, requests from schools and nurseries, locally enhanced services, fees and private work.